Uh,
Yes,
I think
yes,
my
visible,
screen is
visible.
visible.
Perfect,
Yes,
perfect.
ma'am, it
Okay.
is.
Okay. So, if you permit, should I start?
Sure, sure.
Okay.
All screen is yours and all 1 hour is yours.
Thank you, sir. Uh, Now, we would be today talking on a very contemporary topic, that is safety of immunosuppressive drugs commonly used in dermatology during the COVID-19 pandemic. COVID-19, which is also named as severe acute respiratory syndrome coronavirus 2, that is SARS-CoV-2, is a highly contagious virus which has caused a serious global pandemic. Low immunity of the host allows rapid replication of the virus and delays the viral clearance from the body. Now, viral load, as we know, is directly proportional to the damage it causes to the organs, and it can lead to life threatening conditions due to sepsis, multi organ failure, and acute respiratory distress syndrome, that is ARDS. Now, in this condition, one important aspect is that besides the direct viral induced injury, the host cytokine mediated antiviral response also potentiates the tissue damage, which is very important factor for the bad outcome of the disease. Now, before we go to see how the immunosuppressives are safe in the present era, we have to understand what is the effect of SARS-CoV-2 on the immune system of the host. Now, as soon as a host or a person gets exposed to CoV-2, the first step is that the SARS-CoV-2 starts binding. The virus activates the innate immune system, especially the macrophages, dendritic cells, and other myeloid cell types by binding to the pattern recognition receptors, which include the toll-like receptors, which are present on the cell membrane of the host. Now, this is followed by the next step, that is the immune response of the host. Now, as the SARS-CoV-2 binds to the receptors, it leads to production of type 1 interferon and a multitude of inflammatory cytokines, and an adaptive immune system, especially T and B cells of the host, gets activated. Now, this is followed, if everything is good, the immunity of the person is good, then it leads to expansion of the virus recognizing T cells, formation of neutralizing antibodies is stimulated, and the virus is eliminated. So, the third step is the elimination of the virus from the body. Now, in addition, this virus can cause hyperactivation of immune system in some persons, leading to a condition known as cytokine storm. And this leads to very bad outcomes like acute respiratory distress syndromes. Now, if the cytokine storm sets in a patient, then it can be followed by, it rather follows by the immune exhaustion of the patient. The post inflammatory stage or the post inflammation leads to development of exhaustion of the immune system as the disease progresses, and it is accompanied by increased lymphopenia and reduced activation of the T cells. So immune exhaustion of the host occurs, which is followed by collapse of the patient, because the collapse of the antiviral immune response occurs, and this leads to the deadly outcome. Now, the question arises whether the iatrogenic immunosuppression is a risk factor for severe forms of COVID-19 disease. The answer is yes. As we have seen that the complex immune regulation in SARS-CoV-2 leads to too much immune activation of the host, resulting in immune exhaustion, ultimately causes the failure of immune control of the pathogen. Hence, high dose and long term iatrogenic immunosuppression can worsen the course of COVID-19. So, it may be associated with high risk of death of the patient. So, we have to be very uh, importantly thinking about how to consider immunosuppression or iatrogenic immunosuppression in the present era. Now, why we dermatologists are so much concerned? Those who are under immunosuppressive treatment are at high risk of developing opportunistic infections, including the viral infections and the microbial pathogens that may further potentially trigger the dermatological disease. In addition, comorbidities and old age can cause a pro-inflammatory state in an individual, which may further cause higher risk of cytokine storm and worse outcome of the COVID-19 disease. We all know that COVID-19 virus is also a neurotropic virus that has a neurotropic potential that partially explains the high rate of ARDS, especially in the elderly patients. Now, coming to the immunotherapeutic agents which we use commonly, first of all, I would like to share those immunotherapeutic agents which the literature says appear unproblematic in the context of SARS-CoV-2 because of the pharmacological reasons. Now, the first is chloroquine and hydroxychloroquine. It is the these are the immunosuppressive agents which are unproblematic even in the present era. Why? Because chloroquine and hydroxychloroquine inhibit the endosomal NADPH oxidase, inhibit the uptake of virus into the cells. They also interfere with the binding of the SARS-CoV to the AC2 receptors. Thus, they have possible therapeutic efficacy in COVID-19 disease. However, there are no evidences for their protective or negative effect. But as far as dermatologist aspect is concerned, we can safely use these drugs even in the present era. Now, Dapsone, it is effective in blocking the inflammatory storms and it can be promising for the disease itself, and it can also be used by us by you can say, can be used safely in the present times. Now, coming to the most common immunotherapeutic agent used by the dermatologists, that is the systemic steroids. Now, systemic steroids, they cause inhibition of the immune cells, potentially useful in ARDS, even in the COVID. But when these systemic steroids are used in high dosages and for longer course, then they impose a risk of opportunistic infections and they become immunosuppressive in nature, leading to uh, difficulty in the protection from the COVID-19. So, systemic steroids are those therapeutic agents which have to be used with lot of caution. Cyclosporin, it inhibits the viral replication, but it causes immunosuppression and has a risk of opportunistic infections. Methotrexate is a immunosuppressive. Theoretically, it also has the risk of opportunistic infections and eosinophilic pneumonitis. However, the literature is very clear about it that the risk is high only when methotrexate is used in higher dosages, just as the rheumatologists use. But the lower dosages in which the dermatology people are using the methotrexate, it is relatively safe. So, in the present times, methotrexate is relatively safe in the COVID era. MMF and azathioprine, they are potentially worsening the lymphopenia, so they are to be used with caution. Now, IVIG, as it supports the immunity of the host, it is a very good alternative in the present era and it can be considered. Plasma pheresis efficacy is anecdotal in both pemphigus and uh, COVID. Now, coming to the biologics, in the pre-COVID era, rituximab was very commonly used, but now the literature says that it causes long-term immunosuppression, and its effect on B cells is irreversible, and the reconstitution of the B cell immunity of the host takes long time, takes months together, and therefore giving rituximab impairs the antibody production of the host against the virus. So, rituximab in the present era should be avoided as far as possible. TNF alpha antagonists, they cause interruption of the virus induced inflammatory cascades leading to reduction of the disease severity and the lung damage, but they also inhibit the host antiviral defense mechanism. So, they should also be used with caution. Now, dupilumab it, and the other IL-4 and IL-13 this blockers, they are causing downregulation of the ACE2 in the human alveolar cell type 2, inhibit the viral attachment to the ACE2 receptors. So, it is useful in the context of COVID-19. Tocilizumab blocks IL-6, has been proposed to treat inflammatory phase of COVID-19, also reports anecdotally to help pemphigus, so it can be considered. IL-12 and 22 inhibitors like ustekinumab have antiviral response theoretically, but still it not much literature is available. Now, sorry for the crowded slide, but this is basically evidence-based list of drugs and its potential risk in the present times. Now, the high risk drug, as it is written on the first, is the systemic steroids because it has a strong dose dependent risk of infection and sometimes may be harmful. The evidence suggests that it should be avoided and it may suggest harm. Then the drugs which are to be used with caution in the COVID pandemic are the rituximab, as we have already discussed that it is having a prolonged B cell depletion effect, so may consider have a potential harmful effect. So cyclosporin, it requires frequent monitoring. Multiple drug-drug interactions is another factors, and the risk of harm is dose dependent. Then uh, azathioprine and MMF, they have been detailed studied in the transplant patients, and they have seen that the use of azathioprine and MMF in the transplant data, they say that they are more associated with viral infections like HSV and CMV. JAK inhibitors again should be used with caution because they also pose the concern of viral infections like HSV and deep vein thrombosis and pulmonary embolism risk is there. And the TNF alpha inhibitors, infliximab, among the TNF alpha inhibitors, have the highest risks of these problems, causing caution with higher doses like more than 10 milligrams per kilogram should be used with caution or avoided. Now, at present, what we are concerned with is those drugs, those who are having low risk or having no risk. Now, low risk drugs, methotrexate, we have already discussed the low overall risk of infections or infectious complications there with low dosages. It is a safe drug and it may be having higher risk when used in higher dosages or in combinations. Then IL-17 inhibitors possibly increase the URI risk suggested in the recent meta-analysis of the clinical trial data. Then again, there is a theoretical role of IL-12 in antiviral response, though not very clearly implicated in the COVID-19 pathology. So these drugs are low risk drugs. Now, no risk drugs, that is, we can use them safely, are those like apremilast, dupilumab, hydroxychloroquine, then immunomodulatory agents like retinoids, dapsone, and colchicine. Now, hydroxychloroquine, there is no significant risk of infection or infectious complication to date, and it may be used safely. Similarly, dupilumab have been also used safely in the present era. Apremilast, again, it is very much recommended. I will be talking about the recommendations in the later part of my presentation. Now, I would like to discuss special considerations in common dermatological conditions in the present era. Like in cases of atopic dermatitis, systemic steroids used in atopic dermatitis flares should be carefully weighed considering the disease flare versus the SARS-CoV-2 susceptibility. The literature says that cyclosporin has anti-COVID properties, but it is only documented in vitro studies. So there is an head-to-head comparison has been made between methotrexate versus cyclosporin, and they have found that the infection rates in atopic dermatitis patients were 32% and 24% respectively. Now, I am talking as far as the literature is saying. Retinoids, they say that they are safer alternatives today in the present COVID era for psoriasis patients. Why? Because retinoids, they are not immunosuppressant. In comparison to methotrexate, though they have increased susceptibility to only cellulitis, it has been reported, but that is also only because of the increased skin fragility and staphylococcal colonization. So retinoids are safer alternatives in psoriasis. Azathioprine off-label used in atopic dermatitis, but it is associated with higher risk of serious and opportunistic infections as compared to methotrexate, steroids, and cyclosporin. Now, the literature says that apremilast is a good drug because it only modulates the immunological cascade and does not suppress the immune response of the host. Thus, it is associated, though it has been associated with the nasopharyngitis and URI, but it does not increase the risk of serious infections. Hence, according to literature, apremilast is a safer option. Now, these are the algorithms which are available in the literature for management of common conditions in the dermatology. Now, first of all, this is the algorithm for management of atopic dermatitis in the COVID-19 pandemic. Now, according to this, they say that dupilumab is recommended for atopic dermatitis. It is safe. When you are seeing a patient, then for dupilumab you can continue, you can initiate it. Dupilumab is helpful in asthma. It may consequently reduce the risk of severe COVID-19 disease and even may prevent the bacterial skin colonization in atopic patients. And when you give dupilumab, you only require the counseling of the patient for a normal protective measure. Just to take, the patient just has to take normal protective measures. Now, as far as cyclosporin and methotrexate are concerned, they should be used with caution because we should consider delaying these therapy start of these drugs because they are moderate to strong immunosuppressants. And uh, when if we are to use it, then we have to counsel the patient aggressive protective measures. The patient has to be told for home quarantine and all the aggressive protection from the COVID exposure. Now, according to the literature algorithm, they say that azathioprine and systemic steroids they should be deferred. Do not initiate the therapy unless unavoidable. Consider the dose tapering before discontinuation. But if the patient is positive, then it should be. Now, this is the algorithm for the management of psoriasis in the COVID-19 pandemic. According to this, they say that apremilast and acitretin are the drugs which can be continued or even can be initiated because they are not immunosuppressant and they require only normal protective measures in the patient against COVID. While the IL-23 inhibitors and IL-17 inhibitors, though they can be continued, but in that case, again, normal protective measures are enough. As far as ustekinumab and other IL-12/23 inhibitors are concerned, then switching of the drug is required. Again, consider the initiation delay or switching of JAK inhibitors and TNF-alpha inhibitors. Uh, then cyclosporin and methotrexate, again consider delay and defer systemic steroids. So this is the algorithm in the literature available for the psoriasis patients. Though I will go to different case scenarios also in the later half of the presentation. Now let us come to the different clinical scenarios in psoriasis. This was a very good review article in which they have explained the various scenarios the dermatologists have to face. So let us see the first scenario, which we commonly encounter in our OPDs, are the chronic plaque psoriasis, localized type, involving less than 10% of the body surface area involvement. Now, here we will be having two possibilities. One is if the patient is a new case, then the literature recommends to start with topical corticosteroids or topical calcipotriol along with emollients. Now, if the patient is an old case already on systemic immunosuppressants, then stop the systemic treatment, maintain the patient on topicals and emollients. Now, here the patient has to be advised to stay home quarantine at least for 3 months, maintain all the protective measures like hand hygiene and mask, etc., to avoid the exposure. Then the second scenario the literature has come forward with is the chronic plaque psoriasis involving more than 10% of the body surface area, which may be with or without the disabling psoriatic arthritis. In such scenarios, the uh, evidence says that the physicians should discuss the risk and benefit with the patient and his attendants before you initiate the therapy. So it should be a shared decision of the physician, the patient, and his attendants. You have to counsel the patient. We have to explain the risk and the benefits of the various possibilities of treatment. And if we find that the patient is young, healthy adult with no contact history, does not have any comorbidities, in that case, we can start with apremilast, which may be even given with or without hydroxychloroquine. And if the person is having severe joint pains, that NSAIDs can be added in the form of indomethacin or naproxen. Then scenario three is when the patient is having pustular psoriasis or rheumatoid psoriasis. Now, according to the literature, systemic acetyltratin is the drug of choice in the present scenario for these patients, and emollients to be added up. Now, the scenario four, which is very common in our hospitals, is the psoriatic erythroderma. Now, if a patient with psoriatic erythroderma comes, excuse me, we have to admit the patient IV fluids as required, and the literature recommends starting of safer drugs like acetyltratin or apremilast or their combination. If we do not get any response, in that case, we can initiate methotrexate or cyclosporin only after discussing the risk and benefits with the patient and the patient attendant. And during the admission in the hospital, patient should be counseled and should be told to use normal surgical mask for 24 hours and to maintain proper hand hygiene. When the patient is discharged, he should be told to stay home quarantine for at least 3 months. And the follow up should be as far as possible through teledermatology. Then the scenario 5 is when the patient in the pre COVID times were already on biologics. Now, what does the literature say about this? Because if the patient in the pre COVID times were already on biologics, now the literature say that a proactive biologic discontinuation can lead to treatment failure via formation of anti drug antibodies and would cause disease worsening, increasing the hospital visits and having a negative psychological impact on the patient, which will again aggravate the disease. So, and if there is due to the chances of failure of biologics because of anti-drug antibodies, we have to switch the biologics in the future, which will increase the cost of the treatment. So, then the literature says that sudden stoppage of biologics will lead to higher pro-inflammatory states and could worsen the cytokine storm in COVID-19 affected patients. Therefore, the basic summary of the story is that the discontinuation of biologics to prevent COVID-19 infection should be personalized. That is, case by case decision should be done with shared decision making, explaining the patient about the risk and benefit, and then the decision should be made depending upon the patient's high risk. If the patient is high risk, in that we have to think over again whether to give or not, the age of the patient, their you can say other risk factors, and all the other cofactors have to be seen. Now, in atopic dermatitis, the literature is very clear that topical treatments with emollients followed by topical corticosteroids and topical calcineurin inhibitors should be the first choice. But there are scenarios which they will not suffice, like severe atopic dermatitis not responding to topicals requiring systemic therapy. Then we have to think what to do. So then when I have gone to the literature, I found that the literature allows us to start with low dose corticosteroids, less than 20 milligrams per day prednisolone, for less than or for 2 weeks. So we can start this for response, and when the response comes, then this can be followed by stoppage and maintenance with the topicals. Now, here the patient has to be counseled that when we stop the systemic therapy, patient has to be counseled to use ample topical therapy and has to be counsel to be doing a judicious use of emollients and antihistamines to be undertaken, so that the patient does not go into again the flare. So patient has to be told to use judiciously emollients and antihistamines to be continued, and the patient has to be home quarantined for 3 months. And even if then, if these they are not working, then low dose methotrexate less than 20 milligrams per week has also been used and can also be given. Now, the other scenario is when there is stable atopic dermatitis, but the patient had an acute flare up in the severe form. In that case, also, the literature is very clear that short course of oral corticosteroids for less than or equal to 2 weeks, followed by stoppage and maintenance with topicals, judiciously using the emollients and antihistamines, may help the patient. Now, coming to the other common dermatological condition, that is pemphigus vulgaris. So, especially those who are in the government hospitals, they are very much seeing these patients even now. So, various clinical scenarios described in the literature in pemphigus vulgaris includes scenario one. Now, this scenario one is that if a patient is a new case of pemphigus coming to the dermatology department, having extensive skin erosions and oral mucosa erosions. Now, what should be our plan of action? We have to admit the patient, a proper skin care with barrier dressings to be done. In addition to oral corticosteroids, which the literature says can be given 1 milligram per kilogram per day, but they say that IVIG can be considered rather than the conventional immunosuppressive drugs, because IVIG is a booster of the immunity of the patient. So IVIG can be considered rather than the conventional immunosuppressives which we used in the pre-COVID times. Now, if with this remission is achieved, then we go for a slow tapering of the glucocorticosteroids. And now the question will appear that is IVIG available? No, we don't have. We are a resource poor country, and everywhere we are not having IVIG. In that case, literature says that where IVIG is not available, then conventional immunosuppressives like MMF may be given. Now, here, one thing which is clearly written in the literature is that in the pre COVID times, rituximab would have been the first choice in such a case. But as we have discussed, due to its irreversible long term immunosuppression, which it causes, B cell immunity is suppressed for a long period of time. It increases the risk of viral infections. So now, in the present COVID era, it is not advised to be started at present, even in such patients. And when the patient is with us in the ward, patient need to use mask for 24 hours. When we discharge the patient, we must ask the patient to have a strict home quarantine for 3 months, and the patient should be followed up, preferably with teledermatology, ideally, because we should decrease the hospital stays. Hospital visits should only be allowed when there is severe disease flare. Now, the scenario two is that a patient who was a chronic pemphigus case with us, registered with us, or was on DCP, dexamethasone cyclophosphamide pulse therapy, and at present without any skin lesions. Now, what to do about them? It is very clearly written that if no skin lesions are there, DCP can be withheld and the patient can be started with prednisolone less than 20 milligrams per day if required. But here it is important to emphasize that oral cyclophosphamide should be stopped, as the combination of oral steroids and cyclophosphamide causes more immunosuppression as per the literature. Now, in the bullous pemphigoid, since these patients are elderly with comorbidity and are not able to even go for self care because they are old patients, and they have various comorbidities like diabetes, hypertension, and other comorbidities. They are on polypharmacy, so they are on increased risk of severe COVID-19. So, first of all, we must ask the patient for strict home isolation. Now, we categorize the patient. If the patient is the category of mild disease, then we can go for topical corticosteroid. If necessary, if we think as a physician that it is necessary, then oral prednisolone up to 10 milligrams per day can be started. But it is a good adjuvant if we add up the doxycycline or tetracycline, and dapsone can be given. So this may help us to avoid using of oral prednisolone later on in the disease. Now, the scenario 2 is the when the person comes with a severe disease. So topical steroids and oral prednisolone up to 10 milligrams per day, if it is sufficient to control the disease activity, is all right. Dapsone is a very good alternative that should be added along with doxycycline and tetracycline. But besides this, IVIG and IV omalizumab has been mentioned in the literature. Intravenous omalizumab 300 milligrams once a month can be given, and high dose IVIG has also been recommended for severe disease. Now, what about our acute emergencies? Patients of Steven Johnson syndrome and toxic epidermal necrolysis in the present time, what to do? In the current scenario of COVID-19 pandemic, IVIG is preferred treatment to arrest the disease activity, because IVIG is safe, it boosts the immunity of the patient itself, and it is also helpful in our SJS and 10. Now, another promising alternative which the literature is giving is plasmapheresis. Now, here, what about the steroids? The literature is, I had searched the literature and I found that steroid usage in SGS10, the literature is silent. There is no comments even in the present era, and as such, steroids also are controversial in these conditions. So, IVIG, plasmapheresis, this have been written in the literature for these drugs, for these emergencies. Now, besides the avoidance of the causative drug or the causative agent, that as all other things have to be done, but we have to see that as far as use of uh, steroids are there, it is always controversial also, and it is the literature is silent also. Now, dermatomyositis, uh, I had seen some papers about that. Dermatomyositis may produce severe myositis. It may lead to severe muscle pain, weakness, and sometimes dysphagia, dysphonia, and dyspnea due to weakened esophageal and respiratory muscles, presenting as medical emergencies. So, in that case, uh, if the patient is coming up with the acute and severe myositis, earlier, though we know steroids are the first line of treatment, but to avoid immunosuppression because of risk of COVID-19, IVIG has been considered as first choice. After control of myositis, then low dose of immunosuppressive therapy can be started. Now, the scenario 2, when a patient of stable dermatomyositis with normal muscle enzymes on corticosteroids earlier and another some sparing agent, in that case, corticosteroids should be tapered off and other immunosuppression suppressives should be stopped. Now, as I was going through the literature, I found that very interesting cutoff range of low dose immunosuppressive therapies which are permissible during the COVID pandemic was mentioned. So I thought to share with all of us that these what the low dose immunosuppressive therapies are defined as. So low dose immunosuppressive therapies, the literature says that the following dosages they have been found to be relatively safe without increasing the infection risk, and they are defined as, like in cases of low dose corticosteroids, it is less than 20 milligrams per day of prednisolone or equivalent, short or long term or alternating days, but less than or equal to 2 weeks usage. Now, low dose methotrexate is considered when it is given in less than zero point 0.4 milligrams per kilogram per week or less than 20 milligrams per week. Low dose azathioprine has been defined as less than 3 milligrams per kilogram per day. So these are the cutoff range for low dose immunosuppressive therapies which are permissible even in the COVID pandemic. Now, let us come to the expert recommendations on the use of biologics in the COVID times. Now, all the experts, may it be American experts or European experts or International Psoriasis Council, they almost have similar recommendations. They say that if the patient is not tested positive COVID-19, does not have any sign and symptom of COVID-19, in that case, the physician has to weigh the risk versus benefit of the use of immunosuppressants and the biologic medications on a case by case basis. So we have to see to which type of patient we are giving. What is the age of the patient? Does the patient has comorbidities? Is he on polypharmacy? Is he having other risk factors? So case by case basis, we have to decide the usage of biologics and the immunosuppressives. Now, those who test positive for 19, all the experts, they say that discontinue or postpone the use of immunosuppressants and biologic medications. And what about initiation of biologics? Consider the biologic initiation, what to decide. These the third category, they say that the physician has to weigh the risk benefit in low risk patients. uh, Again, you have to say, if even the patient is low risk, then if you want to initiate the biologic therapy, you have to be very open with the patient. Case by case basis we have to decide, and we have to be discussing, and counseling should be done with the patient only then. This is for low risk patients. For high risk patients, uh, the initiation of biologics should be deferred, and alternative therapeutics for high risk patients should be considered. Now, here, according to the experts, what is the definition of patients at high risk of complications? They are more than 60 years of age, those with serious chronic medical conditions, for example, cardiovascular disease, diabetes, severe hypertension, liver disorders, kidney disorders, patients with respiratory compromises, patients having internal malignancies, or those who are using tobacco for a long time. So these are the high risk patients in which biologic therapy should not be initiated, it should be deferred. Now, here I would like to share with you the guidelines of usage of immunosuppressants in the COVID times by various established international associations. Now, first of all is the British Association of Dermatology guidelines. According to the British Association of Dermatology, they say that the patient has to be assessed upon a high risk assessment scale of 7 points. And according to them, the high risk patients include those who have taken two or more than two non biologics, those who are on systemic steroids of 20 milligrams or more for more than 4 weeks, the patients who are on combination of a oral steroid at least 5 milligrams per day for more than 4 weeks, and one systemic non-biologic or biologic. Then those patients who are taking cyclophosphamide, rituximab, or infliximab for a dermatological condition, and certain specific subgroups who take a single non-biologic systemic like methotrexate or some biologic drug, and the patients who are more than 70 years of age, pregnant females, patients having comorbidities, which I had mentioned earlier. So these are all high risk patients, and in them, the use of biologics should be avoided. The immunosuppressants should be used with caution. Then comes the NICE guidelines. NICE guidelines is National Institute of Health and Care Excellence guidelines. Now, the most important pinpoint emphasis the NICE guideline give is that communication with the patient. They say that any decision you make regarding the use of immunosuppressives or the biologics, you should have a shared decision with the patient, communicate with the patient, tell the patient and his attendants about the safety, about the risk, benefit of the drug, and tell them that they should be made aware that the patients, that when you take immunosuppressives, you may have atypical presentations of COVID-19. So patients who are taking, for example, you can give the example that the patients who are taking prednisolone may be even afebrile in spite of being COVID-19 positive. So these patients should be well informed. This is the first point they say. Then they have very clear recommendations that if a patient is confirmed or a systemic COVID-19 patient, we can continue with only topical treatments according to the NICE guidelines. Then, if a patient is known or suspected COVID 19, you can continue with SCQS, chloroquine, mepacrine, dapsone, and sulfasalazine. Now, temporarily suspend biologics in suspected or confirmed COVID 19 cases. So, this is what the NICE guidelines are all about. Then we come to the most prestigious AAD guidelines, that is the American Academy of Dermatology. Now, American Academy of Dermatology has a little slight different view. They strongly advise uh, the patients not to stop biologics without consulting their physician. They say that the physician should have a clinical judgment and should discuss with the patient, should take into view the original indication for which the immunosuppressives were given, and to see how severe the indication was, what is the patient's age, what are the comorbidities. Now, all these factors have to be considered, and they say that you cannot outright reject or stop it. So, what the final AAD recommendations say is that the patients with no sign or symptoms and those who are not tested positive for COVID 19 can continue systemic immunosuppressants and biologics with all the proper precautions. And those who are tested positive for COVID 19 are advised to discontinue or postpone initiation of biologics. Now, for high risk groups, biologics should be postponed. So, this is what the AAD guidelines say. Now, there are many other important guidelines. I will just go as a passing reference. Now, the recent National Psoriasis Foundation COVID-19 Task Force, they again also emphasizes on the shared decision making, depending upon the potential benefit of the treatment, the response to the previous treatment patient was taking, what is the activity of the disease, what are the risk factors for poor COVID outcome in the patient. These all things keeping in view, the patient should be counseled and a decision then should be made. Then chronic systemic steroids should be avoided according to them, especially when the patient is in cases of psoriatic arthritis. They say that telemedicine should be preferred if it is possible. Then optimize safety of phototherapy, which I will be sharing in my later part, where phototherapy, they have also given recommendations for that. Then they say that SCQS and chloroquine prophylactically should not be given for COVID-19 because it may flare the psoriasis. Then International Eczema Council, there one thing important they are saying is that the patient with active COVID-19 infection either temporarily discontinue the systemic treatment or consider dose reduction. The IC recognizes that uncontrolled asthma is also a risk factor for COVID-19 pneumonia. So, such cases need to be considered on case by case basis when we put the patient on treatment. And patients with asthma and comorbidities controlled with systemic treatment such as dupilumab, IC suggests that continuation of dupilumab is useful in these cases. So, according to the IEC, patients without COVID-19 infection who may be infected but are asymptomatic or have mild symptoms only should not interrupt suddenly the medications. Then Medical Dermatology Society COVID-19 Task Force, they also emphasize on shared decision making. And according to them, the decision should be made on 4-point system. One is the severity of underlying condition for which the patient is being treated, the relative level of immunosuppression attributed to the given therapy, need for the monitoring, because if the patient requires lab monitoring, patient has to come again and again to the hospital, so we have to see the monitoring, and the comorbidities. These are the 4 points on which we have to decide the treatment. Again, Canadian Dermatology Society has almost the similar, same as the other governing bodies. The recommendations are same. And they have given one important point is that apremilast and thalidomide are safer drugs and can be continued. And a case-by-case evaluation for patients using systemic steroids, azathioprine and cyclosporin. Now, here I have also gone through a very nice the National Psoriasis Foundation COVID-19 Task Force guidelines for the psoriatic disease. They have also come out with the protocols for during the phototherapy. That is, how can we reduce the risk of SARS-CoV-2 transmission during phototherapy sessions at our hospitals? Now, for them, they have taken patient's protocol and the staff protocol. According to the patient protocol, the patient should be screened for signs and symptoms of the COVID-19 before entering the phototherapy unit. Understanding that treatment will be denied to symptomatic patients, we have to tell the patient this. Attend the phototherapy appointment alone, not to bring many attendants with them. Only minors can be accompanied by their guardians, and with all the safety protocols observed. Then hand sanitizers to be applied upon entering and leaving the phototherapy unit. Patients should be provided with goggles. Those must be sanitized thoroughly according to the instructions, and wear a mask. Unless phototherapy treatment has to be done on the face, the mask should only in those cases it should be removed. Otherwise, mask should be used. And physical or social distancing, proper social distancing should be practiced. And this National Psoriasis Foundation COVID-19 Task Force has also given guidelines for the staff protocol. The staff is advised to schedule the patients of phototherapy approximately 30 minutes apart per the unit, or the per booth. And physical or social distancing in the waiting area, 6 feet apart, seats should be there. Um, Mask, eye protection, hand sanitizers before and after each patient encounter, it should be done. Then avoid turning on the fan of the phototherapy unit if possible. If need be, treatment can be fractionated to avoid the excessive heat buildup in the unit. Disinfect the high touch surfaces in the changing area after each patient. Disinfect the high touch area of the phototherapy equipment in between the patients. Provide the patient with disposable bags to store the personal items. Provide goggles to patients if need be, and ensure that they are properly sanitized and stored in an individual bag. So these are the protocols which are given by these, which are very handy when we are running a phototherapy unit in our hospitals. Then the guidelines, what are the basically the summary of them is that the most important consideration is determining the risk status of each patient based on the age and associated comorbidities when we decide upon the treatment plan, or if we change the plan of treatment during the pandemic. The guidelines also stress the importance of open communication with patients. As we have seen, all the governing bodies, they are stressing on this fact that open communication with the patient should be done, including open, you can say, to be very open, telling them about the treatment plan you plan, and what are the risks of that plan, what are the benefits, and make a shared decision before you plunge into that plan. Now, establishing an environment where patients are encouraged to ask questions and vocalize their concerns, because it's very natural in the present times. They will have their questions, they will have their queries, and we have to be prepared to answer them. Now, these are the Indian considerations, that is, considerations for decision on immunosuppressives during the COVID-19 pandemic. This is our Indian literature. What does it say? Uh, Primary disease and its severity, we have to be very much clear about it, whether the disease is mild, moderate, severe, or in remission. Now, we have to also assess what is the immunosuppression status of the patient. That is, whether a patient is on immunosuppression already, or have been planned for immunosuppression. Do you want to change in the immunosuppressant due to inadequate response to the existing treatment? So we have to first of all consider this part. Then we have to examine for associated comorbidities, whether the patient is elderly, has existing cardiovascular disease, some lung disease, hypertension, diabetes. They are high risk patients for COVID-19. So in these cases, the plan should be very cautious plan. Then we have to see whether the patient can or cannot be strictly homebound, depending upon the occupation of the patient. Now, can or cannot it will depend whether the patient can completely self isolate at home when the patient is on immunosuppressive. When we put a patient on immunosuppressive, we have to be clear whether the patient can go for an home quarantine or not, or can he self or she self isolate at home. Then if we are treating a patient, we have to see whether the patient can go for self care. Is it possible for him to do a self care, or does he require a close contact, or a relative or caregiver is essential? In that case, that close contact or relative or caregiver, he or she can completely self isolate or not when the patient is on treatment. Then we have to see whether patient is accessible to teledermatology consultation. Is it possible for him? Is it accessible? Can he assess it? What is the COVID-19 status of the patient? If the patient is positive, then we have to see that in that cases these are to be avoided. And if the patient has no symptoms to suggest COVID-19 and there is no risk factor to acquire COVID-19 infection, then the treatment plan will be planned accordingly. Then we also have to consider the general prevalence of COVID-19 in the region of the patient's residence. What is the incidence there? So these are all the considerations before making a decision on putting the patient on immunosuppressants during the COVID-19 pandemic. So the take home message from my side is that a thoughtful pharmacological selection should be done. Number one, we should consider the baseline indication, the comorbidities, the co-medications while we continue the immunosuppressive drugs. We have to adhere to the basic infection prevention principles. Reduction of iatrogenic immunosuppression should be considered as far as possible. In confirmed COVID 19 patients, one thing important is never stop steroid abruptly because there are chances of adrenal insufficiency. So we can slowly taper them off. Methotrexate, as we have seen, it is risky at higher dosages what the rheumatologists use, but it is relatively safe at our dosages, at dermatological dosages. Dupilumab is a safe biologic, but rituximab should be avoided. And the crux is teleconsultation, especially elderly patients and those who are on immunosuppressives. If it is possible, it is the best solution to avoid the exposure. So these are the various papers and review articles which are available. And the first thing we should remember is that first do no harm. Thank you so much for a patient listening.
Well, thank you very much, Survi. It was indeed an excellent lecture and a very informative thing which you have done it. Let me first write. So, thank you very much, Dr. Lalit. Can you please take up
Yes,
questions in these things?
yes, sir.
For-
There are some
at the same
questions
time,
in the
I
chat box.
put down the quiz also. Those who are interested in the quiz can participate in that.
So thank you, Dr. Surbi, for your comprehensive, lecture on what to do, what not to do with the immunosuppressants during this COVID times, and it was a practical guide and very comprehensive one. Now we have some questions in the chat box. One, Dr. Sunita Gupta, she is interested to know what about the topical methotrexate during the COVID times? You have talked about the systemic methotrexate. So how about the status of the topical methotrexate?
Topical methotrexate we can use, though they are. I have gone through the literature and did not find any recommendations or any paper on it regarding the use of topical methotrexate in COVID times. But as far as my opinion is that topical treatment can be given because all the other topical treatments are being, you can say, recommended during these times also.
And as you said, low dose methotrexate can otherwise be given. So
Otherwise,
I
we
think topical would be still safer.
And
yes.
on whatever the safest limits she has spoken, looking at the literature,
We hardly exceed
we
that.
do not use more than that.
Yes,
Do not use more
Absolutely.
yes,
than that.
yes.
So she's also wanting to ask about the severe ENL treatment,
Yes.
if,
Somebody
if
asked us your name.
you
Yeah.
can't give steroids in a higher dose, for example, if a patient with severe ENL comes, so how should you go about it? And particularly if she's a female patient of reproductive age group.
That is the problem. Otherwise, thalidomide has been
Yeah.
written, but that we cannot give in these patients. So, in that case, I could not find in the literature regarding this, but low dosages of steroids can be given. 20 milligrams can be given, but otherwise, um, they are not much on the no. You can say the silent literature, light literature is silent regarding this. It not much in the literature regarding this, and I also myself personally do not have the experience of using
But
this.
in such a cases, we can give high dose of clofazimine, right? Because you can write up to 100 milligrams 3 times a day, which is known for reducing the ENL.
Hydroxychloroquine can also be used as an alternative.
Hydroxychloroquine can be
Yeah.
given. Yes, yes.
I think clofazimine is quite safe.
Yeah.
Sometimes nowadays we were finding some difficulty in procuring the clofazimine. I do not know whether, but at Jaipur, I did not find it.
Yeah, I mean, you are right, Dinesh. You are right. It's not easily available, but somehow I think you can manage to get it at least in Bombay, especially from leprosy units. They
Right.
can provide.
I think Dr. Pai once, told me that if you want thalidomide, you can get it from me because he has some, quite a good store of thalidomide.
Who?
But Lalit, thalidomide is available in Jaipur.
Thalidomide is available. Probably earlier it was difficult, but now thalidomide
Now
is.
it is openly available.
And
So, Dr. Surabhi, it is what a rather excellent lecture, and you have served the whole literature. And did you find any article which has a comparative statement of saying that
Pardon, sir, I
there
am
is
not
an
able to. The,
increased
Your voice is breaking, sir.
your
Your voice
voice
is
is
not
breaking.
coming clearly.
yours, your net is not working properly.
especially those who are already on the.
Sir, I am not
Can
able
you
to.
hear me, Dr. Surabhi?
No, your net is not coming proper.
No, sir.
Can you repeat your?
My, my question is, Dr. Surabhi, could you find any article or any study which has comparatively studied the mortality in dermatology patients during COVID? Is there any increased mortality of the dermatology patients who are already on the immunosuppressant therapy?
No, sir. Till now, no comparative studies are not there with keeping controls, non-COVID controls versus COVID patients having dermatological conditions, use of immunosuppressives. So I could not find, sir, any such study. I think it is a little premature at this time.
Any study
It may be
which
coming
shows
up in
the
the future.
increased mortality?
It may be coming in the future as more experience of the use in
Okay.
of these drugs in COVID patients will be there. At as for now, we don't have anything on it.
Dr. Saple, welcome.
I would
Yeah,
like to share
yeah,
I would like to share the experience of one of our patients who she is still admitted in our ward. She had come to us with a tuberculosis, permanent tuberculosis, and was having some skin rash. That is why she consulted us, and we were thinking it to be due to some anti-tubercular drug. So we admitted the patient in our ward because she had bullous eruptions also. And meantime, she developed COVID positivity also. She was sent to the COVID specific hospital, COVID dedicated hospital, and where we continued with the high dose steroid also in this girl. And then she became negative. There was no increased incidence of any bad type of the complications in this girl, and she is still admitted with us and is on the 2 cc of the dexamethasone per day in our ward. So what I meant to say is that though whatever you have said is true that the immunosuppressant might lead to the increased complications in COVID, but still in our day-to-day practice, how much is this relevant? We should agree with the American Academy recommendations then that the immunosuppression should be continued even if during our this COVID time.
Yes, sir, I totally agree to it. As our experience, as my experience in my hospital, also, we are seeing that we are giving immunosuppressives and steroids, and we are not finding any problem in them. So I think the this what I had shared with all of you was what the literature is saying, but our experience is still to be shared with each other. And I found that again, just like you, I go with you that yes, we are not finding any difficulty or any complications by even giving high doses of steroids and other immunosuppressives adding upon. It is not creating problems.
Yes,
Dinesh,
and frankly speaking,
Dinesh,
whatever guidelines are there.
shall I add something?
Sure, sure.
Yeah, okay. Yeah, let them finish, then I'll
Yeah,
add.
sure, sure.
It's okay? Yeah. Talking about the COVID, I am actively involved in the managing the COVID patient, where I'm attached to All India Institute of Diabetes. There is a team of big 10 doctors who we see a lot of patients, and then we have a discussion. Now there was the outbreak of mucormycosis Gangaram Hospital in Delhi. So they were just thinking. And as a HIV clinician, I learned from HIV and what happens to the HIV patient in COVID. It will be surprised those HIV patients who were admitted with the COVID. We used to do CD4 count, and CD4 count was 4 and 5, whose CD4 counts of 400 before COVID, 500. Because if you see, the COVID one a diagnostic point in CBC, the patient comes with this fever, the lymphocyte is very important. The lymphocyte percentage is less, you can say that mostly the patient has got COVID because lymphocyte goes down. That is a CD4. What is CD4 is nothing but lymphocyte. So this HIV patient, you go to 3 to 4. The same things happen. Now it has come with the steroid, dexamethasone, cheap or the cheap what they are talking. Usually they give minimum for 6 weeks to 2 months. They don't give for 1 week or 2 weeks. And those patients I have seen, their CD4 count goes down very low and they get mucormycosis because they're low CD4 count. Similarly, as doctor said, they get tuberculosis. We have seen tuberculosis, herpes zoster, tinea, extensive tinea, herpes simplex virus on the buttock. We have seen a lot of cases. This because and now we are keeping the track. I have suggested all those physicians will do CD4 count because they are not used to do CD4 count. I said once they get COVID, we should do CD4 count, which is not the guideline also. We are working on that. So CD4 count goes down. And Surabhi, your talk was very good, but as you say, if you are giving steroid, not see complication, I think I do not agree with. If you give steroid, you mentioned in the lecture, giving for 2 weeks is not a problem. But if you give for a longer period, definitely there is sustained depressed immunity. And then you get reactivation, whatever is there in our body. Like sacral HSV, herpes simplex virus. See, one of the medical college, one of the professor of radiology, his father developed, so he was admitted in the hospital for 1 month. He developed this, he was treating for as a bed sores. They said, sir, I heard your name. He was in another medical college. Can I bring your father? I said, don't bring, just send the picture. And in HIV, we used to get the sacral, always used to mistaken for the bed sore, that is was HSV. I said, is just start acyclovir. Third day, I got a photograph for the first day, third day, 10th day, and 12th day, everything clear. So what I'm saying, whatever it is present in our body, it gets reactivated, including tuberculosis. But if you give for a longer period, if you give, as you mentioned in that if you give a short period, it's not a problem. So I have suggested in the patient who has got COVID, look for the CD4 count. That will give idea, because CD4 gives idea about the what are the opportunity infection can occur. Like mucormycosis occurs usually in advanced uncontrolled diabetes patients, or HIV. We have seen few cases. Like the same things happen here, because if you see The mucormycosis was not reported cases, but Oxford University says start dexamethasone. So now they are starting dexamethasone to every patient, and they start 6 weeks to 2 months, not 1 or 2 weeks. That is the problem. So I feel CD4 counting, if you can get up your patient, you will get also your own experience, Yeah.
It's a very good suggestion. We can do it. CD4 counts can be done in all the patients on which we are planning to go for immunosuppressants
Yes,
beforehand.
yeah.
Yes.
COVID,
Very,
I'm
yes.
talking about the COVID
Dr.
patient.
Yeah,
Yeah,
Kable,
good. Yes.
yeah,
Good. Very
Dr.
good suggestion, sir.
yeah,
Dr. Kable,
yeah,
so since you said CD4 count is going to be very important, I
yeah.
think why don't you advise to the government of India or any other task force that CD4
Yeah,
count
see,
should be done
now,
routinely?
yeah, because what we have done in the All India Institute of Diabetes, where the group is there, we have started doing, let us collect some data, because I have got a data of my HIV patient who developed COVID. I learned from that. So now we are doing even non HIV. I remember once I was talking about herpes zosters in a young people or atypical presentation. Dr. V.R. Joshi, who is known for the immunologist, he said even ASL you get recurrent herpes zoster. Because there also immunity goes down, but nobody looks for CD4, no, those conditions. Yeah, but it's a good suggestion, Dr. Nagpur. I think I'll suggest. Thank you
Yes,
very much for that.
so that it can be done routinely for every case.
Yes, correct. That's right.
All right, sir. Very, very nice discussions and these things. And I think today's meeting was a very excellent compilation of the data and the things by Dr. Surabhi. Surabhi, thank you very much once again. And if there is no any other question or comment, let me say good night to all and end up the
Okay.
meeting.
Okay.
Okay, thank you very much and good night all.
No,
Yeah.
thank you, sir. Thank you
Thank
very
Thank
you.
much.
you.
Good
Thank
night.
you.
Thank you very
Thank
much.
you.
Thank you,
Bye.
sir.
Yeah. Bye.